Well, Mr. Chairman, I'd like to thank the organizers for inviting me. And my task is to give you an impression on the laboratory assessment that might be connected to the use of the new oral anticoagulants. Now, if you think that I'll give you a recipe that you can walk out with, I'm going to be disappointing you. I'd like to also tell you up front that I'll recommend to you later on that you should continue monitoring, but we'll see what. Now, okay, got the wrong one. This is just to sum up what potential sites of inhibition that we have in the coagulation cascade. And as you all realize and know, at the time being, we have 3 substances available in Switzerland: rivaroxaban and apixaban as 2A inhibitors, as well as the dabigatran. But I think it will not take long time until we see another 10A inhibitor to come to market, and that is edoxaban. Now, I'd like just to remind you on that schematic, just to let you know once more that we deal with direct inhibitors of either factor 10A or factor 2A, which plays a part in trying to assess what their function is once they are on board. Now, I'd like to go through that schedule with you, and I've picked up 3 main questions, and that is a NOAC, as they are on the market right now, detectable with regular, non-specialized laboratory assays? I think it's pretty clear-cut that if you have a specialized lab at hand, you will be able to find a NOAC in circulation if it is on board. But the question is, can that be integrated in daily business in most of the labs that not always run specialized assays? The second question then would be, if so, are there other issues that need attention with NOAC detection? So are there any other additional points that need to be recognized or need to be looked for to be able to interpret the finding after the first question? And then third, the very practical one: what do I do if I have a lab result that detects NOACs on board and that is likely to result in bleeding down the throat? Now, this is a recently published work that will show you the effect of dabigatran on normally measured INRs. And as you can appreciate, those bars depict the concentration amplitude in the RELY study. So you see that most of the patients in the RELY study were in this particular concentration range. And you can see that indeed there is a very nice reaction of the INR to the concentration of the circulating dabigatran. However, what you can also appreciate is the fact that the spread of the results clearly indicates that the results are overlapping. So you really can't tell by just looking at the INR whether the dabigatran at a concentration of 100 nanograms per mil is in the circulation, or whether this might be 150 or 200 nanograms per mil. So is there a reaction of the INR to dabigatran? Yes. Can we take the INR or use the INR to detect dabigatran? Obviously, yes, if we are sure, or if we can ask the patient whether he has been taking dabigatran. I think that's the point. If we don't know what the patient has been taken, there is no way to use the INR to detect whether dabigatran or another NOAC is on board, as I'll show you later on. Well, then there's a second point, and that second point is it depends on what lab you're sending your sample to. Because labs are using different machines, labs are using different reagents, and as you can see here, the sensitivity of the one reagent is not necessarily identical to the sensitivity of the other reagent to dabigatran within the same sample. So you can see here that with the one reagent, the slope is much steeper as compared to the other reagents. So beside the fact that you have to be able to ask the question whether he might have been taking the bigatron, you also have to ask your lab what type of a machine, or you would have to ask your lab what type of machine or type of reagent they would be using, so not very practical in a daily business. What about the APTT? Again, you can see a nice increase in the APTT with the bigatron, but once more, the spread is such that you can't use the singular result to predict what concentration of the bigatron is in the circulation. So is there an impact of the bigatron on the APTT? Yes. Can we use the APTT in order to detect the concentration level of the bigatron in the circulation? No. This is a little bit different with the thrombin time, and I'm mentioning that because specifically in Switzerland, thrombin times are still done a lot of the times for monitoring heparin therapy. And as you can see here, the slope with the thrombin time, if the bigatron is on board, is very steep. And this indeed allows you to get an information that is something like an on-off information. If you think that your patient might be on a thrombin inhibitor, and you do a thrombin time on this patient, and you see that the thrombin time is truly strongly prolonged, then you can assume that indeed he has a thrombin inhibitor on board. And the nice thing about it is that the thrombin time will react as fast when the thrombin inhibitor goes out of the system. So the thrombin time, specifically the low-dose thrombin time, gives you such an impression that you can assume that indeed if thrombin time is prolonged and strongly prolonged, it's very likely that the thrombin inhibitor is on board. Now these are results from a multi-center trial, a multi-center study in Switzerland where volunteers had taken rivaroxaban, and then we sent samples out to different labs. And as you can appreciate, with rivaroxaban, you also have an impact on the PT, so on the INR measurement. Between different labs, different machines, you might see different results, but in general, there is an overall impact. Yes, factor Xa inhibitors, and here rivaroxaban, do influence the prothrombin time. They increase the INR. The same thing as we've seen with the APTT for the thrombin inhibitor is shown here for the factor Xa inhibitor, and you can see that the APTT is also influenced by the factor Xa inhibitor. And if you think back to the very first schematic that I showed you, it's very likely that this would happen because both factor Xa as well as thrombin are involved in the common pathway, which is an important part of the actions that come down to measurement of PT or APTT if you look at it in the lab. Now, what about more specific assays? And in our studies, we have also looked at the kinetics of rivaroxaban in the volunteers, and we did both. We did at the same time HPLC-MS-MS, which is a very specific assay to detect rivaroxaban, so you can be really sure that you see rivaroxaban in the given concentration. And at the same time, we also measured anti-10A activity in those particular volunteers. And as you can see here, they essentially overlap all the time. So the factor Xa activity very effectively displayed the influence of the rivaroxaban and was comparable to the true concentration of rivaroxaban in the circulation of these probants. Now, coming back to those three questions, is NOAC detectable with regular non-specialized laboratory assays? Indeed it is. And that's because the NOACs either inhibit factor Xa or factor 10 or factor 2A, which, as I told you, are part of the common pathway influencing both the PT and the APTT. However, they are not specific, and chromogenic assays are sensitive and specific, but the point is they are not substance specific. So if you have a chromogenic 10A assay, it will not be able to tell you whether this patient is on rivaroxaban or perhaps on another anti-10A drug. But it will tell you that this patient is on an anti-10A drug. So if so, are there other issues that need more attention with the NOACs? And I'd like to show the kinetics of the bigatron. And if you now realize that you might be taking a sample at this particular point in time, or you might be taking a sample on this particular point in time, or even at 12 hours, in all of those samples, the patient is considered to be on the bigatron. But this is a clear difference to the VKA, because the VKAs didn't give you such a peak and trough situation, which is the fact with the new oral anticoagulants. So if you collect the sample at the peak level, you for sure will see an influence on the APTT, on the PT or the INR. But if you do that 12 hours later, all this influence will be gone in a patient that eliminates the substance normally. Now, the point how to remember this is that you probably can assume that the kinetics are very much different to what you're used to with low molecular weight heparins. These are different pharmacokinetic profiles of different low molecular weight heparins. So in daily business, time-wise, you can think about new oral anticoagulants as if you were using low molecular weight heparins. So the pharmacokinetic profiles between the NOACs and the low molecular weight heparins are very comparable. This is true for rivaroxaban. This is true for apixaban. Now, what else is to be considered? We were talking about those peak levels and the half-lives, but one important other thing has to be considered, and that is the route of elimination. And as you already heard from the foregoing speakers, renal insufficiency really is an issue to think about. And why is that the case? Because 20 to 30% with the 10A inhibitors and 80% to 90% of the 2A inhibitors are cleared, of the active drugs, are cleared renally. Now, think about the other thing, that is age. And why am I saying this? The biggest group of patients that will be treated with the NOACs are patients that have atrial fibrillation, and those patients usually are in the aged group. Now, what about the kidney function in this age group? And you see here data from the NHANES. As you can see, the chronic kidney disease is picking up in prevalence, and we have a considerable amount of people in the normal population that do show renal insufficiency at the point in time when they are going to be considered for anticoagulant therapy for atrial fibrillation. And more than that, the highest risk factor for acute renal failure, partially on top of chronic renal failure, is associated with the presence of heart disease or stroke. Again, the particular population that we look at when indicating the use of the new oral anticoagulants. So, are there other issues to consider? Yes, they are. You have to consider about, if you look at the collection of the sample, you have to be aware of the pharmacokinetic profile of the drug and for the renal function of the patient, because the renal function of the patient might change your pharmacokinetic profile. And what do I do if I have a lab result that detects NOACs and is likely to result in bleeding? Well, these are data from the RELY study, submission data to the FDA that are publicly available. As you can appreciate, you have the occurrence of bleeding. This is the bleeding incidence curve. You do have the occurrence of bleeding over a very wide concentration range. And that not only holds true for the bigatron, but this also holds true for rivaroxaban in the ROCKET study. So point is, there are no such results because from the level of NOACs measured, we cannot predict whether this patient is going to be bleeding or not. We just had a case of a suicidal attempt with rivaroxaban in St. Gallen. We measured a 10-fold increased dose as compared to the data from the ROCKET study, and nothing had happened. The patient didn't bleed at all. Nothing, not that much. So that was a very interesting experience. In conclusion, I think the NOACs have to be considered as influencing many coagulation assays, as I showed you. Also, the assays that depend on the PT assay or the PTT assay, such as coagulation factor measurements, will be influenced. Thrombin time is particularly sensitive and therefore helpful in thrombin inhibitors. But again, the most accurate and specific assays would be chromogenic assays using for measurement of specific anti-10A and 2A. However, given the fact that we cannot predict bleeding with these assays, it's not, at least not at the time being, it does not seem appropriate to use them outside a bleeding case. A considerable variability of concentration has to be recognized, and that's why you should think about when you collected the sample, if you interpret the results of that particular sample. And as I promised you, kidney dysfunction should be monitored, but not the function of NOACs. And with that, I thank you for your attention.